For some of the precancerous lesions and for some of the maybe early skin cancers, we do have some non-surgical treatment options. Like any treatment or any solution in life, there's some upsides and downsides. With the topical treatments, one of the issues is that you do need to apply it for a few days to maybe a few weeks, and it causes an inflammatory reaction in the skin. Another treatment that we have that has a smaller downtime, I would say, is photodynamic therapy. So this is a procedure that's done in the office. A nurse or a physician may apply a topical medication. This medication is preferentially taken up by all the atypical cells. We spend probably a few hours letting that medication sort of incubate in the skin. That can be anywhere from an hour to up to 3 hours. And then the patient sits under a special light for a certain amount of time. That light activates that medication. So all those cells that were abnormal that took up that medication have sort of an inflammatory burst, and they're essentially killed off with formation of some oxygen radicals and inflammation. Right away after that treatment, the skin becomes a little red, and all those areas that may have had precancerous lesions will become a little red. You might have some peeling, and that could take up to about a week of time where the skin is responding to that treatment. With surgery for any type of cancer, our goal is to remove the entire cancer, to prevent this cancer's ability to return, and to try and give the person who's undergoing the surgery a good outcome both functionally and cosmetically. But as far as treating the vast majority of skin cancers, I would say surgery still remains your best treatment option, and I think provides still the highest cure rates. We have some minor surgical procedures that we might do for a superficial skin cancer, something called electrodesiccation curettage. We are using those techniques when the cancer is limited to the top layer of the skin. Think of sort of a fruit that has an area that's going bad and that might be a little mushy. You know how you can scrape or cut that part off? We're actually able to scrape off the cancer cells. We have, by that technique, we're able to tell when we hit or are entering healthy tissue. It has a different feel, it has a different sound. So we're able to scrape off the cancer cells. We cauterize the base of it, so using a little heat and electricity to not only stop the bleeding, but kill off some of the remainder cancer cells. And that's a nice technique for lesions that are very superficial because you are not cutting into the skin. When you're talking about lesions that get into the second layer of the skin, the dermis or beyond or deeper into the dermis, then something like a scrape and burn that may not be sufficient. And at that point, you really need to do a surgical removal. Depending on the location, depending on the size, depending on the aggressiveness or the histology of the cancer, we might be doing an excisional procedure or we might be doing Mohs micrographic surgery. Both are surgical procedures to remove the skin cancer, but how that cancer is removed and tested is a little bit different. With a lot of skin cancers that we develop on non-critical sites, such as on our chest, back, arms, and legs, we will actually do an excisional procedure where we remove a margin of normal skin. We know we have a very good chance of obtaining clear margins and very high cure rates. When the cancer might be in a critical site, like somewhere on the face, particularly near important, critical, and functionally important structures like the eyes, the nose, the lips, or the ears, or maybe on the hands or feet or genitalia, where you don't have a lot of tissue to work with, and conservation of tissue is important, function is very important. That's where Mohs surgery comes into play. What we do with Mohs is we actually cut conservatively right around the skin cancer without taking a sort of an arbitrary or standard margin, and we're able to process the tissue right away. With Mohs, you're really actually tracing out the tumor. So our ability to remove the entire tumor and get a high cure rate is phenomenal. Cure rates are so high, you're talking about 98 to 99%. Once the skin cancer has essentially gone beyond the skin and has metastasized or spread into the lymph nodes or beyond, that's really where we rely on systemic therapy, and our medical oncology colleagues are usually involved at that point in treating the patient. So for advanced cancers right now, for the longest time we were limited to certain types of chemotherapies, and they really sort of attacked any rapidly growing cells. That's where you had all the side effects that people often associate with chemotherapy, so hair loss, problems with sloughing of the lining of your mouth and esophagus and things like that. And so those were therapies that were done before. Now we actually have more targeted therapies that are targeting particular proteins that are expressed on both skin cancers or on immune cells that are fighting those skin cancers. So those targeted therapies, whether they're growth factor inhibitors or if they're targeted therapies in the immune system, now we're able to actually target squamous cell or advanced skin cancer better. I think this is a new era in skin cancer treatment, and I think we have things to offer patients that we didn't have even 5 years ago. Thankfully, with skin cancer, I think most of the time I don't spend time talking to patients about recurrence because both excisional surgery and Mohs surgery has such a high cure rate. I think what I often worry about is actually other lesions coming up. So new primary skin cancers. Once a patient has had a skin cancer, we tell them that there's probably, now we know a little bit about your skin history and your risk here. So if you're fair skin and you're developing the skin cancer, we know that there's probably a good chance you might develop another one. And the numbers are anywhere from 40 to 60% chance of developing another skin cancer. So we tell patients you are someone who should see a dermatologist at least once a year and get a good skin exam. You know, it's hard to give up French fries and it's hard to get on the treadmill, but I don't think it's that hard to put on sunscreen. So, you know, it's an easy thing. We don't love to have an extra task, but we're not taking you away from something pleasurable that much. So sunscreen should be a part of a daily routine. It's like deodorant. You don't leave your house without it. So sunscreen, wearing a hat, cover your arms, long sleeve. It can be light colored, loose, so you keep cool, but it covers yourself. Pants, long sleeves, a hat, because even with the best of sunscreens, the issue is that most of us are not putting enough on, as much as we should, to get that protective factor, and most of us are not reapplying it every few hours. The vast majority of patients I see, they have a cancer, and unlike many other cancers, I can look them in the eye and tell them this is cured, you will not need to worry about this, and now we're going to work on prevention for other skin cancers. I think that's the joy, and I think that's why derm surgeons and Mohs surgeons tend to be happy people, because we get such good cure rates with our patients.